All right.
And action, guys. Welcome to our last presentation of nursing school ever. Okay.
Don, Derek.
I'm Derek.
Tammy.
Tammy. Thanks for listening to us.
Subscribe now.
All right, go for it. Who's first?
I'm first. So, in IDing the problem, so first of all, we're doing short peripheral catheter starts and education and increasing the efficiencies of shortening the amounts of pokes that we give to the patients for starting IVs. So, the problem is that IVs are being placed for practitioner convenience and not for patient comfort. And the lack of skill is resulting in 2 or more attempts to start an IV on a patient. And these multiple sticks to the patients are causing a decrease in increasing patient dissatisfaction and increasing discomfort in the patients. So in assessing the problem, the average first time for starting the rates for floor nurses is about a 50 to 60% success rate. IVs are typically changed out between 72 to 96 hours. And the staff, one of the problems is that the staff primarily picks the antecubital fossa to start the IVs. And these IV starts are time consuming and often are pushed off to others for tasks.
Okay, so the driving restraint and comparison. There was studies that were done that was comparing the knowledge, confidence, and skills of staff nurses who received very little education, kind of like us, going into a Sims lab, poking a mannequin's arm that has already been poked 1,000,000 times, and comparing that with nurses that have received more extensive education regarding IV insertions. And so they rated the confidence on the ones that kind of like hit it once, nailed it, had a first time success, compared to the ones that that didn't get it like 2 or 3 times trying to get the insertion. So skill deficits obviously are identified, and this was also included in a patient assessment. The selection site, of course, for the IV, the dwell time, the complications left, and the treatment and the compliance with the best practice guidelines. And so the complication rates of these IVs were phlebitis infiltration, catheter occlusion, catheter dislodgements, and catheter-related infections. So amongst that, we have to deal with the costs, and the costs, if they're not done correctly, then we have to summon somebody else that has, for example, a PIC nurse has to come in, and that costs more money and causing a national financial burden, and it's estimated about $1.5 billion here in the U.S. annually, and the failure rate is about 35%. Multiply the estimated 150 million IVs that are placed at a low complicated procedure cost of $28. So, so over 300 million IV sites are IV start kits are sold, and 200 million are placed in patients. So we got 100 million that are not being successful. The average stick costs about $45. A double stick, $69. Triple stick, $125. And that doesn't even include the assessment of what the patient feels like after having been stick over more than once. So, so what they're comparing for evidence-based practice is to focus on technology rather than traditional methods. So, such as getting the IV monitor that can see the vein finder, to use that instead of the traditional, going right for it and missing. So, so the patients during this this research, they found out that when they used the technology, there was a lower number of IV insertion attempts compared to those that just received the traditional training. So, and then we're going to go into our plan.
So our plan is to implement an annual certification class of didactic and skills learning. So we realized that
the only time we really have the opportunity to learn how to start an IV is really in nursing school, and it's really towards the beginning. So us being towards the end of our program, the last time we really fully learned hands-on was really at the beginning, which was like 2 years ago. So everybody, once they become a nurse, they kind of just get put on the floor and they're expected to know how to start IVs. Whereas if you don't have that, if you don't have that confidence from being able to learn it enough in clinical, they kind of just, you have those people on the floor that you know, like, oh, they're good at sticking people, let's go ask that person. So that takes away that time that that nurse has to give to her patients to start IVs on other people. And to also do biannual IV start days for all Venus Access staff members, so that they are like more, so that there are designated staff to do that instead of just pulling other nurses off the floor. Increased knowledge pertaining to non-pharmacological techniques, and this is, like applying heat, bringing a lot of circulation to the hands, kind of like milking their hands or their fingers for glucose checks, and teaching staff to utilize technology assistive devices such as the vein finder. So a lot of people were talking about how it's kind of looked down on if you need to use a vein finder, because you're not as competent as other nurses who can just do it really easily. So we should kind of teach the staff that these are encouraged to be used so that we can get like that stick successful the first time. And the goals would be to increase first-time IV start rate to 80% within 1 year. And all staff members are trained and recertified annually, so that, again, they have that opportunity at least once a year to relearn any new, any changes or any better ways to start IVs. And then increase IV site infection education to transition to clinically indicated relocation. Yeah, so those are the 3 goals.
Okay, so as far as implementation and carrying out this plan, is what we thought would be useful is making sure that the training is overseen by specialist vascular access nurses. That way we can make sure that they're specialists that can bring that education to the staff and providing the skills and training that they've received throughout their career. And so they'll be able to organize this program to get set up, like Nikki was saying, the annual recertification classes and to set up the biannual start days. And that way nurses get an opportunity from the floor to come down and work with these specialists and make sure that they can hone in their skills and give them the opportunity throughout the year to practice those hands-on and educational sessions. So these staff members will be teaching these classes from anywhere from 8 to 10 hours, depending on the overall skill level of the nurses that are in the class. So that'll range by the competency of what's going on. So it doesn't have to be 10 hours every time, and it can be a little shorter if needed, but we want to make sure that everyone has an equal opportunity to receive that training so that they can increase their confidence and competence in these skills that in order to increase their success rates. And in order to make the class successful, we felt it would be best to limit it to 20 students per session. That way the instructors have enough time to work one-on-one with the staff members that are coming in for training that day. We don't want it to just be a class that they come in for, they sit, they get their hours, and they go home. We want it to actually benefit the members of the hospital and the employees working here. That way we can increase that patient satisfaction by decreasing the amount of times individuals have IVs started. And again, like Nikki was saying, switching to that clinically indicated transition time, which we'll talk a little bit more about evaluations on that. And just overall, we want to make sure that we provide educational materials during this class, both in printed handouts and through a reference bank that would be established that has the ability for the employees to come in and look at videos, read up on evidence-based practice and the current teachings of ways to start IVs, ways to identify phlebitis, ways to identify inflammation, because like we were talking about earlier, that knowledge deficit of identifying an IV that's gone bad is one of the big hindrances on why we're changing them out every 72 to 96 hours. And so being able to make that transition, proper identification and assessment of IVs is very important.
Awesome. So I was part of the evaluation phase of everything. So this is the end of the nursing process before you start it all over again. So we want to see if all of these things that we're implementing are actually working and what effects they're having on the actual situation problem that you could call it. So first thing we would want to do is do a systematic evaluation, and it would be conducted quarterly. And what we would do is do an analysis of the following things I'm going to list. So first thing would be accurately tracking the number of attempts to start an IV. We want to see how many tries it's taking a nurse to actually start an IV. We don't want to kind of cater to somebody using 10 sticks to get one functioning IV. We want to kind of catch that earlier on and see what the problem is and what the issue might be there, and kind of remedy that ahead of time before that many sticks are implemented. Next thing is IV Start Confidence Questionnaire. That's how we would kind of assess how the nurses on the unit feel about inserting an IV. Do they feel comfortable with it? Do they not feel comfortable with it? Would they prefer if somebody else did it, maybe like a specialist like we were talking about earlier? Next thing is peripheral IV catheter or intravenous catheter insertion skills checklist. Pretty much just a checklist to ensure that everything's being done in the proper way, in the proper manner, order of events and everything like that, and it's all following a standard of guidelines. And then lastly would be peripheral IV catheter insertion knowledge assessment. Just it's kind of like a secondary evaluation. Just making sure your nurses understand the process, the materials, and kind of like the pros and cons of each site, what would be better and what would be more patient-centered care, and benefit the patient in the greatest capacity. And we have our reference list here.
Okay.
Any
Yeah,
questions?
do you have any questions?
Yeah, I wanted to go back when you were talking about the cost of starting an IV, and you gave me the 45 for the first attempt, 69. Is that just for supplies, or does that include time spent, the staff time spent?
I think that's better.
It's both.
It's both.
Yeah.
Okay,
The
so
greater
it's like the total
expenditure, the
time.
greater expenditure from what we saw was staff hourly rate was higher
Okay.
and the supply rate was lower. We weren't able to get a direct rate for Mountain View supplies, but on a national standard, it seemed to be about $3 to $5 for an IV start kit.
Okay.
And the remaining cost was just staff time.
All right, and then you're implementing this plan, with doing education, annually, quarterly, so that, will this also be implemented as part of the hiring on process? So new employee orientation, will this then be included in that also?
So that would be up to the discretion of the hospital, but I definitely think it would be beneficial if with the new incoming employees, they had an opportunity to receive that training. And then again, annually on essentially their hiring anniversary, they'd be able to complete that training again for recertification. And then I did notice that you said quarterly for the training. So the quarterly was just our evaluations
Right,
for the
okay,
hospital to measure the actual growth and success of the program to make sure it is meeting standards and that the hospital is spending money in a good direction to increase that staff knowledge and patient satisfaction.
okay. Well, it sounds like you guys have really thoroughly researched this, so it sounds like a very feasible plan, so hopefully you'll be able to have staff discuss with management to help implement this program. Okay, I don't think I have any further questions.
All right, thank you.
Thank you.
Thank you. Appreciate it.